second part of your portfolio. Okay, so autonomic nervous system. Again, we're thinking something more automatic. We're thinking of a lot of the functions of the body that we don't have too much really conscious control over. So you would think of the most basic aspects of who we are, which is going to be body temperature maintenance, heart rate, blood pressure, respiration rate, filtration ultimately of urine, filtration of blood to get us urine, digestion, absorption of nutrients. All of those things just happen. We don't really think about them. They do, however, happen with regards to the neuroendocrine connection. The nervous system is involved, so we could call this the autonomic nervous system. So basically, the role is to gather sensory information from inside the body or outside of the body. Those are those sensory pathways that we call the afferent pathways. So this is that point where we're kind of thinking about homeostasis going all the way back to week one. We're getting into, again, really the most basic aspects of our ability to survive and to function. So that afferent sensory stimulus pathway coming in, and again, it's coming internally from different organs and tissues and cells. We're getting information from our cutaneous sensory receptors from outside of the body. We're getting light from the eyeballs, and we're getting sound through the ears, smell through the nose. So we're getting sensory kind of coming in all of the time, both externally and internally. So we know this already, right? We've already talked about kind of our reflex arcs and that. So we're going to definitely have a motor component. And again, up to this point, generally the motor components of our reflex arcs have focused primarily around more of the somatic nervous system, getting more into the response, leaving the central nervous system is heading out towards a skeletal muscle. So we're going to see flexion of the biceps, or flexion of the elbow, and the biceps and brachialis contracting, or whatever it might be. That's really the kind of the nervous system up to this point that we've really discussed. The autonomic part is no different. The only difference is the efferent paths, the motor pathways, what we call the response pathways, are not necessarily going to be going to skeletal muscle exclusively. They're going to be going to smooth muscle tissue. They're going to be going to different glands in the body. They're going to be going certainly to the cardiac tissue. So that's the major difference. If you're asked the difference between the somatic and autonomic nervous systems, primarily, again, we're looking at where these efferent pathways take us. Where do these motor pathways go? We're thinking, again, more cardiac, smooth muscle tissue, and glandular tissue. We call these autonomic effectors. Okay, so most of our glands are going to be autonomic effectors. Okay. Again, you don't have to tell your pancreas to start secreting insulin. You don't have to tell your sweat glands to start perspiring or sweating. You don't have, it's automatic. These are responses and effector pathways from, again, this autonomic nervous system. So we do have two divisions now. So now we've got more divisions. So we don't stop at just somatic and autonomic. We go one more division off of that. Well, I guess two divisions, but we have two separate kind of yin and yang, or up down, or stop go kind of mechanisms involved here. So part of this autonomic nervous system certainly is going to involve maintaining our normal homeostatic rhythms, right? Like the heart rate of 60 to 80, or even up to 100 beats per minute, 120 over 80 for your blood pressure, 98.6, and in those tiny range for body temperature. These are all going to be maintained by nervous system, by efferent pathways, by autonomic effectors. And that particular branch or division we call the parasympathetic. So, parasympathetic has to do with just kind of maintaining homeostasis, resting, digesting, those types of things. So, when you see parasympathetic, you're generally thinking of keeping us in homeostatic balance. Okay, this is your rest and digest system. So when your heart is beating, we talked about the vagus nerve a little bit last week when we did cranial nerves. And that vagus nerve does leave it leaves the cranial cavity. It's a cranial nerve. And remember, the vagus is the wanderer or the traveler. And one of the places it's going to go is down to the heart. It's going to kind of help to maintain the pace or the normal rhythm of the heart. So that vagal stimulation and vagal rhythm that you may hear on the clinical level is going to involve maintaining a normal heart rate, getting it back to a normal rhythm. So the parasympathetic paths generally these autonomic effectors, they're generally going to come off of the cranial nerve pathways. In fact, that vagus nerve is the link between the brain and most of the vital organs of the rest of the body. So how do we how does the how do the kidneys function? Well, they function because the nervous system, and in part that parasympathetic autonomic nervous system is just keeping the kidneys regulated. How the liver, the small intestines, the gallbladder, the pancreas, on. I mean, it just, the list goes on, right? The stomach, every organ in the body is connected directly to the brain via that vagus nerve. And again, you would think of that as being the parasympathetic pathway. Now, when there is a situation where some sort of stimulus is coming in that may need to elicit a response that is a little more active, then we would call that the sympathetic pathway. The sympathetic pathway of the autonomic nervous system, it has to do exclusively with stress. So when the stimulus comes in, that there's a stressor. The stimulus is a stressor. Some stressors are also known as triggers. These external stimuli can trigger a stress response. So the parasympathetic pathway keeps us regulated. The sympathetic pathway is what gets triggered during stressful situations. So associate sympathetic with the other S word, stress. Okay, sympathetic and stress are they go hand in hand. Heart rate goes up, body temperature goes up, so we perspire or sweat more. The pupils dilate, the respiration rate increases, blood pressure goes up. I mean, all of these things go up when we're faced with some sort of a stressor. Digestion, however, kind of ceases or slows down. We see what's called vasoconstriction, or blood vessel diameters shrinking or going down in the abdominal region to kind of get a lot of the blood out of the digestive system and into more of your you know your skeletal muscles to either fight or flee. So when you hear about sympathetic nervous system, stress, you're also thinking of the phrase that you've probably all heard at some point: fight or flight. Okay. Excuse me. So fight or flight, that's the sympathetic pathway. So on a clinical level, we go back to set points. When our patients come in and they have chronically high blood pressure or issues with respiration or breathing, They've got metabolic problems. They've got hormonal imbalances. These are oftentimes linked to stress. So, and linked to that sympathetic nervous system being kind of, triggered a little bit too much. So again, we're seeing a lot more on the clinical level regarding discussing coping skills and lifestyle management and lifestyle awareness, consumption, exercise, diet. All of those things certainly aren't new, but on a clinical level, they are a little bit more discussed than before. So that's a good thing. We need more of our patients. We need more of us to have better coping mechanisms when faced with stressors. We need to be able to maintain our parasympathetic, homeostatic norms as much as possible and throughout the day. And so again, it's the stimuli and the perception of stress and filtering and what are your triggers and paying attention to your body's automatic responses to what the brain is receiving and what the brain is absorbing. Okay. Like today, I mean, today is a perfect day, I think, to be probably talking about. Every day is a good day to talk about the autonomic nervous system. But today, right, the election, this has been, yeah, it's like this every 4 years, right? It's the big presidential, it's the biggest one. It's always the big one, right? Every 4 years. Some of you are young, so this could be the first election you've been eligible to vote in. So that's pretty cool. You have two candidates. Well, you have more than two, but you have two candidates that are definitely kind of polarizing, and so yeah, if this is your first election voting, I could see maybe why you'd be like, maybe I'll wait another 4 years, give it a shot then and see what happens. But it's I'm 45. My first election that I was able to vote in was 1996. So Bill Clinton, that's a long time ago. So all of you have certainly heard of him and heard of Hillary, but that's how old I am. So I voted in, I don't know, three, maybe four presidential elections. So it's if it is a day though that a lot of people get really wound up about. They get really stressed out about it. They've been stressed out for every day leading up to this point. I mean, if it wasn't for COVID, all we'd have been hearing about in the year 2020 would be the election. So we get kind of a double dose. We get COVID and the election. And so thankfully we've been able to come together in here and not really have to think about that stuff or worry about it. But it seems like, wow, it's kind of a big deal for a lot of people, and we're doing the kind of the stress system and that, so yeah, a lot of people are going to be pretty elated with the results. A lot of people are going to be pretty upset with the results. There's going to be quite the polar dividing range of emotions, and so yeah. So be aware of that, and hopefully you yourselves understand what triggers your stressor buttons, and so hopefully you keep those minimum and try to maintain as much balance and normalcy in your lives, and really kind of take a more objective approach at a lot of things that really we don't have a lot of control over. So if you vote and you vote for local stuff, that's great. You might have an effect on that, but really getting too upset about anything or getting too excited or happy or elated, you want to kind of maintain your composure throughout. And again, that's one of the anti-aging serums, is really understanding how to cope with stress and how to certainly recognize different triggers, and to again maybe cut them off at the pass, or don't allow them to take up real estate in your brain. And then you guys, man, you'll be golden. I'm probably preaching to the choir. I'm sure all of you are just perfectly calm and balanced and don't have any stressors in your lives, or if you do, you manage them well. So if you don't, I hope that you are on the way to being able to at least understand and recognize and carry forward a healthy, balanced attitude and in your lives. So anyway, because that's why all your pay. My point is, everybody that's coming to see you in the clinic, they have a hard time with that. So they definitely don't want to see a nurse that's really gloom and doom, or really up here. We really need neutral to neutral positive, very objective, very, we're happy to have these patients in here so we can enable them and enable their bodies to start functioning at a better, more parasympathetic place, as opposed to functioning at a sympathetic place. So basically what you're doing is helping, and what we're doing in the clinic is helping to kind of reestablish these new set points that tend to lean more towards being parasympathetic. So chronic stress is a killer. We know it is. And so it's our jobs to not allow it to affect us, other than in a way that we're enabling patients to enable themselves to have better coping skills and be less stressed out. So sounds easier than it is, but yeah, you never know. So, but it does come with your behavior too. And so, yeah, they come into the clinic like, yeah, okay. They're an example. And if you have kids, or someday you will have kids, if you don't already, you're going to be an influence to them, and behaviors learned. And if you're calm and balanced and mature and steady with your children, man, that's the best role model. And if you're the same way with your patients, you're a role model to them too. So anyway, this is just a nice little diagram showing the autonomic nervous system and the central nervous system, and kind of how all of this works. It looks like a jumbled mess, so I'll break it down a little bit. What they're trying to show is, within the central nervous system, the brain and spinal cord, that's where you're going to find these autonomic integration centers. So you're not going to we're not, and all that means integrating what? Well, this is where we integrate sensory coming in and motor going out. This is the control center, right? The integration center. This goes all the way back to week 1 in homeostasis. So outside of that central nervous system is the peripheral system. And again, this is where we're going to have sensory pathways. This is the visceral receptors. So again, these could be external or internal receptors. So stimulus comes in. So that's that one sensory pathway heading into the dorsal region, and then certainly up through those ascending tracts. Now, again, this is the reason I put this in here, is to show that we do have 2 separate possibilities, right, for motor response. Okay, for that efferent response. Is it going to be the sympathetic pathway or the parasympathetic pathway, right? If it's the parasympathetic pathway, again, this is where we're kind of maintaining normalcy. This is maintaining homeostasis. So these are cardiac, smooth muscles, glands. Okay, we've got adipose, where we store a lot of nutrients. And then again, if we go down that sympathetic pathway, this is the as needed pathway, right? This is not, we don't always need that stress. This is as needed. So when the bear jumps out at you, or when you have an unexpected event that happens, you have to be ready, and you have to be prepared. So that's where that's so it's just showing we have separate kind of pathways. And again, this parasympathetic pathway, a lot of that is coming off of your cranial nerves, whereas we're going to see the sympathetic pathway is going to be what we call chains, or sympathetic chains. These are ganglia, or bundles or groups of nerves connected by more nerve fibers that again are kind of outside of the spinal cord. It's almost like a secondary spinal cord. So that's what we see with the sympathetic chain. So we can get a quicker kind of, we can elicit a heart to speed up, and diaphragm and respiratory. So here's kind of what I'm talking about, these different chains. So we look at the sympathetic pathways, and we can see, again, these are the stress responders. So these motor pathways that are heading off of these chains, they are coming from the spinal cord. These are what are going to be increasing heart rate. These are going to be expanding the diameter of some of these blood vessels. We also see, again, heading to the liver, and maybe getting some of our stored glucose moving, going to the pancreas and getting stored, getting insulin and glucagon, getting that teeter-totter rolling. And then we see the kidneys. We're going to see more anti-diuretic properties going on typically during stress, because the body is heating up, so it needs to retain some water to help with friction and to help with body temperature. So remember, ADH coming from the pituitary, and then we saw a couple coming from the adrenal glands, aldosterone. These are going to all play an effect on a sympathetic effect on helping us to retain water, retain fluids. So again, all of these different kind of domino effects to get sympathetic responses to occur are coming off of these sympathetic chains directly from the spinal cord. When we come over and look at parasympathetic, remember, parasympathetic is your rest, digest, homeostasis pathways. Notice these are coming off of that vagus nerve. We have a few other cranial nerves involved, but primarily we see that vagus nerve kind of wandering, and this is helping to maintain normal heart rhythm. This is helping to maintain normal digestion, helping to maintain, again, normal elimination through the colon, through the kidneys, and ultimately the bladder. So we see this back here dealing with some of our proprioception, kind of helping to maintain posture, helping to maintain some of, again, our proprioceptive aspects of our facial muscles. Okay, so parasympathetic, a lot of the connection with our body's internal organs is going to come off of the cranial nerve pathways, especially that vagus nerve. Okay, when we're dealing, so the brain is in direct contact with your stomach and your liver. Okay, the brain is in direct contact with the heart. Okay, brain is in direct contact with a lot of your muscles for posture. Okay. The brain is in connection more indirectly. The spinal cord is the primary link when it comes to eliciting a lot of our stress responses and sympathetic responses. Okay. And again, so I'm going to move on from the autonomic system a little bit. I think some of this is more physiology or functional aspects. I wanted to mention that we do have the division. Let me back up to we have this thoracolumbar chain. Okay, so thoracic and lumbar connected. So that's what this is talking about. Okay, thoracolumbar division. Okay. Again, most of this information is going to be reserved for more functional aspects that we see next semester. So we'll get into the different neurotransmitters. This is chemical level. We'll talk about dopamine and acetylcholine and what are called cholinergic and adrenergic receptors. We can see those two terms here. Adrenergic generally involves adrenaline. So adrenergic is more of a sympathetic neurotransmitter, whereas cholinergic we'd see being involved with acetylcholine, which we'll see next semester enables muscle proprioception, muscle tone, muscles to contract in general. So cholinergic, we think of that as more of a parasympathetic pathway. And epinephrine and norepinephrine, again, these are going to be two adrenaline or adrenergic type of stimulants. Okay, epinephrine. I've heard of an EpiPen, right? If you've, some of you may know folks, or maybe you yourselves are allergic to certain types of foods or certain types of stinging insects. And so an EpiPen will, again, it stimulates the sympathetic nervous system. It's kind of like a jolt of adrenaline. So the heart rate is going to go up. And one of the big things with sympathetic and with epinephrine is it's going to cause bronchial dilation. So it's going to cause the lungs to be able to fill with more oxygen. It's going to get the heart rate going. So yeah, if you have an allergic response, a histamine response, it can cause the airways to constrict. And so epinephrine brings it the opposite direction. So you've probably heard epinephrine at some point. So again, some of the autonomic functions are basically just to regulate and maintain homeostasis, and to also be able to trigger changes when we're faced with stressors. So that's basically what you want to remember about the autonomic nervous system, is that it's part of the peripheral nervous system, and its branches deal with maintaining homeostasis, called the parasympathetic division or branch, and then the sympathetic or stress, increasing most things except for digestion. That is the sympathetic pathway. Okay, so anyway, parasympathetic and sympathetic, those are the autonomic subdivisions. And again, we go through this, we spend a lot of time on this really throughout next semester. This autonomic nervous system is really the bread and butter of what we're doing in the clinic. This is that neuroendocrine connection. This is where pain and inflammation is internally or externally are felt and are responded to. So anyway, that's your introduction. So next semester, when we get to the nervous system, which is right away, first thing we do is nervous system in advanced, this won't be completely foreign to you. All right. So, general senses. Again, I'm not going to do much of anything with this. General senses simply has to do with the sense of touch. So, we're not going to get too much into the specifics of general senses. We do go through these next semester again when it comes to a lot of the stimulus leading to response. So, we have special senses that we're going to talk about in a little more detail here in just a second. We've already hit on a few of the primary terms with the special senses. So I'll review those and then talk about a couple new things, then we'll move on. But yeah, smell, taste, vision, hearing, and balance or equilibrium, that's the special senses group. And then general or somatic senses, again, we're dealing more or less with kind of interoceptors and exteroceptors in regards to touch, in regards to inflammation, in regards to, again, some of our pain receptors. So oftentimes the skin is what we discuss when we're talking about the sense of touch or general sensations. Okay, so we do have a couple of different types of touch receptors, and again, some of these are going to be more for pressure, like tactile receptors. Some are going to be more for what we call pain or nociceptors. So again, we can classify these general sensory receptors as being either external or exteroceptors. So these are going to be what we just looked at here with pain, pressure, temperature. So those are going to be exteroceptors, oftentimes again called cutaneous receptors. Okay. Visceroceptors, also known as interoceptors, just like it sounds, visceral, we're dealing with the guts or the internal organs. So again, if the internal environment is experiencing a little bit more inflammation, If we, if you feel any types of sharp, stabbing, shooting pains in your intestines or in your guts, or your stomach hurts, or you're going through, PMS, or some sort of, bladder infection or something, anything internal. Oh man, my shoulder hurts. I slept on it wrong, or whatever it might be. Oh, I went and raked some leaves. So, any of these internal sensations that the brain is feeling, usually it's related to inflammation. And inflammation is either due to infection, or repetitive use, or overuse, or some sort of trauma that's occurred. So anyway, when we sense, when the body internally is sensing inflammation, that is a definite trigger that's going to get sent to the brain, and cause some sort of cascade of hormones to try and kind of combat, or bring down the inflammation. So anyway, we have visceroceptors, um, and exteroceptors. Now, we have kind of a third one I've mentioned several times. We saw it when we did skeletal muscles a couple of weeks back. Proprioceptors, right? That's your internal kind of body's knowledge of where it is in space. So this helps with tone, muscle tone. This helps with maintaining posture, maintaining balance. Okay, so proprioceptors. Um, Now, these are all of the different types of receptors that we might find throughout the body. Again, these are as general senses, not your special senses. So we have what are called mechanoceptors, or mechanoreceptors, and these are just monitoring physical changes, or physical mechanical changes. Um, Chemoreceptors are more internal. They're again receiving different types of chemicals. So chemical receptors, and again, these could be in the form of neurotransmitters. These could be in the form of hormones. These could be in the form of just about any type of chemical. Okay, chemoreceptors. It could be enzymes. Thermoceptors, or thermoreceptors, are going to, of course, relate to temperature. Noci, that might be a new one. Whenever you see noci as a combining form, or a root that has to do with pain, okay, nociceptors, those are your pain receptors. And then photo, dealing with light, and then osmoreceptors deal with osmotic balance. So these deal a lot with water and fluid balance, as well as, pardon me, electrolyte balance. So sodium, potassium, water balance, all being monitored by specialized receptors in a lot of the linings of our smooth muscles, especially our capillary networks throughout the body, but certainly all of our blood vessels, especially arteries, capillaries. They're going to have what are called osmoreceptors. The kidneys, especially, kind of monitoring osmotic balance. And again, that just has to do with water and fluid balance, as well as electrolyte balance. Okay, so again, these are the different basic classifications of receptors. And again, some of the nerve endings are what we call free nerve endings. These are the bulk or majority of sensory nerves are going to be free nerve endings. Some again are called nociceptors, so they're detecting primarily pain. But we also some of these are going to be detecting temperature as well. So some of the very basic aspects, and not to mention these, because they're free nerve endings, they get kind of a general area of the sense of where the problem is. So this is okay. So it's great for temperature, but when it comes to pain, free nerve endings oftentimes can make it difficult to isolate where pain is. So we have what's called referred pain. So someone may have a pain in the upper shoulder region, or a pain that's kind of in the between their shoulder blades. It kind of radiates radiates up back between their shoulder blades, that could be indicative of something wrong with something else, like the gallbladder inflammation, or maybe there's some gallstones or something. Oftentimes that can refer to the middle of the back, or can kind of wrap around. So a lot of times the free nerve endings are great for pain, in a way that any type of inflammation is going to get picked up by these free nerve endings. So that's good, because that's sending a signal to the brain that, oh my gosh, something's wrong. Typically, again, it's inflammation, and the inflammation that the free nerve endings and these nociceptors are picking up is again in the form of excess fluid in the tissues. And again, it could be due to a viral or bacterial infection. It could be due to some sort of injury. It could be repetitive use, overuse. There are multiple reasons why inflammation exists, but these pain receptors do pick up any type of inflammation that's nearby, which is great because it tells us they do scream loud when we have an acute issue, right? Acute means it's small window. It just came kind of maybe out of nowhere. There could be something we can directly correlate to why I have this acute pain. So maybe I just need to ice it, rest it. Maybe I need some medication or vitamins. Something is lacking. Maybe I just need hydration. So those are acute pains, and they usually yell pretty loudly. So that's what these free nerve endings, these nociceptors, that's great. But again, they do lend themselves sometimes to referred pain and more difficulty, maybe isolating the specific locations of pain. So, but anyway, that's what the free nerve endings. So if we have free nerve endings, we must have kind of encapsulated nerve endings. We see this especially with more specific pressure or touch regions. So again, if I've got an encapsulated nerve and I touch over here, this nerve is not picking up that I'm touching. So it's more specific to a location. So if I'm pushing on or you know, something is some pressure, that is going to be picked up, and it's going to be directed to a specific spot. So the sensory that's coming in, that there's pressure, there's touch, there's something ticklish or itchy, it's more discriminatory of where its location is. So these are encapsulated nerve endings. Ouch, somebody got a little pokey. That's a little hard to look at. This one, letter A, we also have in the clinic something, it's kind of like a pinwheel. It's like a metal, it looks like this. It's an instrument like this, but over here, it's a pinwheel with a bunch of little metal pins, and we'll roll that along the skin area to determine maybe where there could be some nerve damage, and what we call them dermatomes, where this, what line of spinal nerves we may be dealing with. So I think we've talked about that before. So anyway, sense of touch, tactile and lamellar corpuscles. Um, eh, Proprioception, we have what are called muscle spindles and Golgi tendon organs. Muscle spindles are either fast twitch or slow twitch, right? We've got the type 1 and type 2 muscle fibers, and the spindles are basically nerve bundles that are around the muscle fibers. So remember, nerve fibers and muscle fibers are both cell types. So these are all going to be interconnected to one another. And again, this is part of that link with the nervous system. Muscle spindles, again. So when muscles are shortened, that muscle spindle is also shortening. So the signal's telling the brain that, yep, muscle shortening, if the muscle's lengthening, or maybe it gets over lengthened, it starts to burn a little bit, right? If you've ever pulled a muscle or been stretching and it kind of burns a little bit, it kind of is stopping you from going further. Those are muscle spindles that are sending the signal that, whoa, it's like taking that slinky, right? And you get a slinky a little bit too overstretched, and then it gets weird, and then it never quite goes back the way it was. It's got a little kink in it. So what muscle spindles do is, again, they're kind of wrapped. The slinkies like the muscle fiber, and as it's lengthening, the muscle spindles are little wires that are basically connected that tell the brain, yep, 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 okay, okay, that's good, that's far enough, and again, the nervous system, it exists, and these general senses exist, and these afferent pathways of sensory are coming in, again, to protect the tissue, to protect the body. And so if I'm overstretching a muscle, then the brain is gonna get that sensation, and it's going to tell you, it's going to elicit either more muscles to tighten up, to help take, we're going to get more synergists, right? We're going to get more fixators. So to kind of try to stabilize the joint. So again, all of this information coming in and response going out is really for protection, and it's to communicate to you that something is either on the verge of being wrong, or something is already wrong. um, and again, I just sound like gloom and doom all the time. I do apologize, but there are positives too, right? There are, we get into other types of touch, massage therapy, physical therapy, a nice warm hot shower, uh, you know uh, whatever, right? I mean, there are plenty of positive things that are coming in, and some of these too, but they're still temperature related, right? A super hot shower, that excess heat can cause, the stimulus, and then the response out might be, you may start sweating more, you may start having some rest, it could trigger some blood pressure changes. So anyway, Golgi tendon organs, again, these are going to be more in the tendon. So these are going to be triggered especially when we get something overstretched. So you can see where the tendon attaches to the bone up here, and then the muscle here. It's all one continuation, but we do have a type 1 sensory fiber coming up, and just basically, again, telling the brain that, yep, we're stretched just good enough. We don't want to overdo it, otherwise we could detach from the bone, or get some sort of evulsion fracture, where a chunk of the bone breaks off with the tendon because it overstretched. So this helps, again, with proprioception too, not just um conscious movements. These are also proprioceptive. So Golgi tendon, muscle spindles, constantly telling the brain where they're located, where the muscles are located. So that's it for that. I want to just mention a couple things with special senses. We know with smell, we deal with the olfactory region. So we do have the first cranial nerve pair coming in, the olfactory bulb, and then these little tiny nerve fibers coming off of that bulb and heading down through that cribriform plate of the ethmoid bone. Okay, so at the kind of the ceiling or the roof of the nasal cavity, we're going to find the fibers of the olfactory nerve connecting with the olfactory bulb, and ultimately heading down that olfactory tract to the brain. Okay. Um, Again, we're going to scent molecules are what get picked up by these little nerve fibers. Now, they do go through, or have the potential to go through, what's called olfactory fatigue. So if the same smell keeps almost overstimulating those olfactory nerve fibers, they do hit kind of a wall. So you can keep smelling. So we see this, right? Man, oof, I'm sure I was one of these too, but I remember a high school kid. I know I was. I remember being in high school. I'm not that old, but I also was a high school teacher a long, long time ago. And so um, late 90s, 1999 to into 2000. So anyway, oh man, you'd walk down the hallway and it smelled like, every perfume and cologne blended together you could imagine. And this would go on throughout the day. Well, part of the problem is you've got these guys spritzing their cologne between classes, and then they get out of class and they don't smell it anymore, so they think it wore off, so they give it another spritz. Oh man, yep, smells good again. They go to class, and then by the time class, they don't smell it. That rigmarole. So yeah, that's because of olfactory fatigue. All of us can smell it a mile away, but that individual can't because the nerve fibers have basically become tired, fatigued of that specific type of scent molecule. We also talked a little bit about the amygdala and the hippocampus, the direct relationship with the limbic system and the sense of smell. So we'll move on from there. Taste buds. Again, we're certainly going to be dealing with the tongue. We have what's called gustatory. That's taste isn't sciency enough, so gustatory is what they use for taste. We have what are called papillae all over the tongue, and these papillae are little bumps, right? I think we've looked at the word papillae in the past, and we know it means some sort of small bump. And then these four terms just kind of tell us the shape of the bump. What does the papilla look like? Fungiform or fungiform? Does it look kind of mushroomy? Does it more circular? Have like a tube or kind of a pop can look to it? Is it foliate? Does it kind of look like foliage? Does it look like leaves? Or is it filiform? Does it kind of look like a bunch of tubes kind of filed together neatly? So that's what that's talking about. You'll probably never ever see these terms again. I mean, maybe you will. I don't know. Depends on what type of medicine you end up working in. But we do want to introduce you to some of these, the wonders of the human body, and again, structure relating to function. So the structures of these different taste buds does relate to what types of function that they perform. Okay. And again, each taste bud responds to one of the five primary senses. So we do have four different types of taste buds. We generally have five different types of tastes. Um, Four you guys are all aware of. There's a fifth one you may not be. So we'll look at that as well in just a couple of minutes. Before we do, here's just kind of showing, here's some foliate, kind of, again, looks like leaf pattern papillae, and then you have the circle papillae, and then we got to blow it up a little bit. You can't really see the fungiform papillae. The filiform, again, more like, I guess, like little blades of grass almost kind of sticking up. And then fungiform are going to be more like this. It'll be kind of mushroom shaped. So down in these grooves, so we take a little chunk, we blow it up, and in the tongue, in between each of these papillae, there are going to be little grooves. And in those grooves, that's where we find the actual taste buds. So the nerve fibers are going to be down, connecting to these, down in these grooves, connecting to these little tiny bulbs, gustatory cells or taste cells. And again, here you go. Here's some filiforms, just a bunch of kind of blades of grass, and then the fungiform looking more like kind of mushrooms or toadstools. So here are the possibilities that we'd have. So let me go back to this one. So when we look at this little taste bud here, and so that's a taste bud. Hey, it's going to have a little pore right here, so a little juice of molecule comes in, and it's going to get picked up by this taste buds, right? So you got the little pore, and then you have your nerve fibers attached to that. So here are the five options, and again, depending on the area of the tongue we're in, we're going to see more of these, or more concentrated bitter maybe, and less sweet, and so on. Sometimes, though, we may see something a little more like this. It's unlikely we'd see something, well, we'd probably see something like this, but this is again just kind of representation or diagrammatic of the possibilities. So bitter, salty, sweet, and sour. I think you guys have all heard those four as being tastes. And then umami is a taste specific to what we call glutamates. Glutamates, I think they're going to be found in maybe like tomatoes or um, orangey, maybe like sweet potatoes. Might have glutamates. There's one called monosodium glutamate accent. It's called a lot of. It's like a flavor enhancing chemical. Let's see. So, nerve impulses anterior 2/3 of the tongue travel over the facial nerve. So, that was one of our cranial nerves. And then we saw the glossopharyngeal. So, more of the posterior taste buds are going to travel along that glossopharyngeal. And they're going to go through the medulla into the thalamus and then finally into the gustatory region of the cerebrum. So yeah, through the medulla. So taste can certainly, and through the thalamus. So again, we're going to go through that relay center, that reticular activating system. So all the way down in the medulla, taste travels and then goes up through the thalamus and then into the cerebral cortex. Next up, we'll do the ear and then transition to the eye, and then that'll be it. So, with the ear, we do have a couple of divisions. We have kind of, in essence, uh, the external, what you can see of the external ear, right? The auricle, the pinna, the ear lobe. Okay, and then we also have the EAM, which is where you put your Q-tip, external auditory meatus. Okay, so that's the external ear, and then so basically the external ear is what you can see, and then the part that kind of disappears into the temporal bone, and then it's going to meet up with what we call the tympanic membrane or eardrum. So external ear is really just this, and then it ends at the eardrum, and then that begins us in what we call the middle ear. Okay, we have a hammer, an anvil, and a stirrup, or malleus, incus, and stapes. These are tiny ear bones. They're the smallest bones of the body. In fact, these three ear bones are so small they could fit inside of a peanut M&M, if not maybe even a regular M&M. Okay, so we see the external ear and this external auditory meatus. And again, we take a peek inside with an otoscope, and we can see kind of this membrane here. This is going to be what we call the eardrum or the tympanic membrane. And then beyond that are going to be the ear ossicles or the ear bones. Okay, so you can see a nice breakdown. We'll stay on this slide for the ear for the rest of it, really. So you've got the external auditory meatus, and again, this is not to scale. This is probably not quite as long as it's showing. Kind of see, but anyway, okay, so here's the bone, and then we have the eardrum or the tympanic membrane. That's where the external ear stops, and the middle ear begins. And the middle ear section is really quite tiny. There's not a lot going on there. We have those three ear bones, the malleus, incus, and stapes, and notice they're attached to the eardrum or tympanic membrane. So basically, what happens is we kind of funnel different sound waves in, and those sound waves are going to kind of rattle the eardrum or the tympanic membrane, and then these ear ossicles or ear bones, they start to vibrate as well, and they transmit those sound waves into what we call the oval window. So we can see the stirrup is connected to what we call the oval window. At this point, this whole section here is going to be part of what we call the inner ear. Okay, so we can see the inner ear has like a bony labyrinth, and then we've got these what they call a semicircular canals. These are going to be responsible for the vestibular aspect or the balance aspect. So we saw vestibulocochlear nerve here last week when we did cranial nerves, and we looked at these semicircular canals. You have three of them, and they're all in different kind of planes of the body. We've got a more or less like a sagittal, a frontal, and a transverse plane represented, and these are hollow in essence, but they are lined. There's a lumen there, and in that lumen is going to be a bunch of little tiny stones encased in a gelatinous kind of bundle. So as we move, that gelatinous brick kind of moves around as well, and it kind of triggers these little hairs that are connected to the vestibular nerve to, in essence, tell the brain what direction we're facing, and where we're moving. So this helps us to maintain kind of basic equilibrium and balance. And then we've got this cochlea here. The cochlea is the shell-looking feature. This is going to be where the hearing or the auditory aspects are going to be coming in. So as those sound waves are coming in, you can see again the stapes kind of plugs into the oval window. That we have a vestibule here where we've got kind of an entryway, and the sound waves are just going to travel into the cochlea. And then we have that cochlear nerve kind of plugged in there that's going to pick up those sounds and bring those to the brain. We have this little round window, and then we also have the eustachian tube or the auditory tube. These help with some of the noise. They help to buffer some of the sound. So as sound comes in, it's less muffled when we have the round window and the auditory tube opened. So when you have a ear infection or eustachian tube or auditory tube infection, a tonsil infection, because the tonsils are right here, this kind of empties into the pharyngeal, kind of that oropharynx area in the back of the mouth. But if the tonsils get swollen, and then the auditory tube or eustachian gets swollen, ears infected, that can affect your equilibrium and balance. It kind of makes everything sound like it's underwater. So as soon as we get those tubes kind of cleared out, the infection out of there, at that point, we can hear a little bit more normally, and we don't have that kind of underwater sound going on. So, eh, so those who have hearing problems, they could have a lot of issues with some calcifications of these ossicles. We could have, the cochlea, some of the fibers in there get burned out or worn out due to repetitive sounds. So a lot of people who work in are exposed to chronic vibrations and different pitches and noises like factories or computers, or where you have that kind of hum going on all the time. That can certainly affect long-term hearing and cause long-term hearing damage. And so anyway, when they say they put tubes in the ears, they're talking about the eustachian tubes or the auditory tubes. They can make a little incision right in here and go right in and put them in there. And uh, they can also go in through the oral area and get them in that way. Typically, though, I think they go in through the ear. I'm not exactly sure, but I know they used to. Now, again, there's a lot of different ways that they do procedures now, but yeah, they can make a tiny incision here and just kind of guide a tube to go right down in there. And what it does is it keeps and maintains this auditory tube's the lumen or the opening. So there's always the ability for excess sound to pass, and so they can hear better and they have better balance. Yeah, so anyway, those semicircular canals again help with balance. Cochlea helps with hearing. Yeah. Here's these otoliths I was going to tell you about. These are the stones of the ears, and they're kind of encased in this gelatinous blob. And again, they're inside of these semicircular canals. And as we move our heads, these things kind of move and glide as well. And as they're moving, they're kind of flicking these cilia, and then the cilia send signals down toward ultimately the vestibular nerve telling the brain what direction we're facing. So you have the standing upright, you can see that gelatinous blob with the otoliths, and then she bends over. So the semicircular canal is now facing this way, and so that little blob moves this way and tells the brain that we're moving, and this is the direction we're moving. And so yeah, if there are issues again with hearing or balance or both, certainly we can we can treat one, and sometimes the other will come along with it. Yeah. Eyes, we're just about done, and then we'll call it quits. A couple of things with the eyes. We have some of the colors of the eyes. We call the iris, and then the dark circle is the pupil. That's actually an entry hole where light waves are passing through and being picked up by the retina in the back of the eyeball. So the pupil, we often talk about the pupil dilating and constricting when it comes to letting more light in and letting less light in. We have what's called a canthus, the inner canthus, and the external or lateral or outer canthus. These are just kind of the corners of the eye. We can see the whites of the eye. That's called the sclera. The sclera. Okay, so pupil, iris, sclera. And then a couple other interesting items of note. We have this sclera, but as we if we look a little bit deeper, let me go back to this. If we look at this, covering the pupil and the iris and kind of connected with the sclera is going to be, here's the sclera here, and then it kind of continues and becomes what we call the cornea. Okay, so the cornea is kind of like an extra little bubble or lens over top of the iris. Okay, so light comes in, it passes through the cornea first, and notice we have a little tiny chamber here. This is what we call the aqueous chamber, the water chamber. You oftentimes hear it called the anterior chamber of the eye, the front chamber. It's between the cornea and the lens, basically. Okay, the cornea and the pupil and iris and lens. Okay, so this is the anterior chamber. This is going to have mainly a clear liquid. They call it the aqueous humor that's located there. Okay, so then we pass through the pupil and we have the lens of the eye. That takes us then into the posterior cavity. We call this vitreous. So it's a little thicker, vitreous humor. Okay, so aqueous and vitreous, anterior chamber, posterior chamber. We also see a couple little muscles. These are called ciliary muscles. They're like kind of like cilia. They help to, they're connected to this muscular layer. So you can see the sclera, and then we've got kind of a muscular layer here. That's that ciliary layer that's going to be connected to the lens. And again, if we need to focus in, we might need to bend the lens a little bit. If we need to look a far distance, we might need to flatten the lens out a little bit. So focus and the ability to focus comes primarily from, well, a lot of it's from the shape of the eye. A football laying on its side is going to cause the lens to be a little more squished. So these would be maybe more nearsighted. If we have more of a football and a T-shaped eyeball, the lens will be more elongated. So we might have someone that's more farsighted. They can see long distances clear, but they have trouble reading up close. Okay, so anyway, the shape of the lens, the shape of the eyeball oftentimes dictate what type of vision you have. And then the retinal area, kind of the back of the eye, or the kind of the posterior chamber lining of retina. So we'll see that in more detail here in just a couple of minutes. Okay, we also have what we call the tear gland or lacrimal gland. It's kind of like a big shower head on the lateral superior aspect of the eye. So it's kind of always on. There's always going to see a little bit of moisture keeping the eye lubricated. And then again, we have a couple little pores called puncta that are going to be the drainage pipes for that lacrimal fluid. And we know this bone was called the lacrimal bone, where we'd find these puncta. Okay, and then the lacrimal sac connects with what we call the nasolacrimal duct. So all of that is draining medially and then kind of heading toward the posterior aspect, kind of the nasal cavity. Okay, we've got some extrinsic eye muscles as well. You don't need to know the specifics of those necessarily. Just know you have extrinsic eye muscles and intrinsic eye muscles. So, extrinsic eye muscles, primarily named for their position and location. Intrinsic eye muscles are going to be the iris, again, regulating pupil size, and then those ciliary muscles I mentioned, regulating the shape of the lens. Okay, so the layers of the eyeball, again, we have the sclera and the cornea kind of coming together, the outer layer, the fibrous layer, and then we've got more of a middle layer, what we call the vascular layer or the choroid layer. This is going to be that vascular middle portion, meaning a lot of blood vessels, a lot of pigment in that area. This is where we're going to see in the anterior portion kind of the continuation of the muscular aspects of the ciliary bodies and processes, little sensory or suspensory ligaments. And then finally, the deepest or innermost layer is going to be that retina. And the retina is where we see that's where light is coming in. So photoreceptors are coming in. We're going to see what are called rods and cones. And again, these cones are going to be the color receptors, and the rods are going to be more of your tones. So we would see maybe like blacks or shades, I should say. So maybe browns and blacks and those types of shades. Cone for color. Pardon me, cones for color. Okay. CO, cone and color. Rods are non-color. A lot of animals don't possess very many rods, so they may see more in the evening, more at night. Your nocturnal group is going to lack cones, or at least very many cones, so they're going to be rod, you know, primarily full of rods in their retinas. And you see that reflection or that kind of the glow of the eyeballs of these nocturnal creatures. And then we have some animals, like some fish and birds, they see color. It's part of their mating process. So we know that if we analyze the retina of certain fish or birds, we would find cone cells in there. So anyway, and then finally, that retina layer, that inner layer, is also going to be connected with the cranial nerve number 2, that optic nerve, as well as some of the blood vessels that we find that are feeding the eye. So uh, when we look at the eyeball, we're shining a light through the pupil. We're actually seeing the retina and the vascularization. There's a little disky area called the fovea centralis, and that whole region is called the macula. And the macular degeneration is what leads to blindness as one possibility for blindness. So hypertension, excessively high blood pressure, they're linking that to vision and it's the quality of vision. So as we age, our vision generally gets worse anyway. But if we have chronic hypertension and other issues with blood and vascularization, that could certainly lead to some issues with vision. So again, anterior cavity in front of the lens, posterior cavity behind the lens. Posterior cavity is much larger. And again, we have some liquid in those humors, the aqueous humor in the anterior cavity and the vitreous humor in the posterior cavity. Okay, so from the lens forward is that anterior, what we call the anterior cavity of the aqueous with aqueous humor, and then the posterior cavity with vitreous humor. And then this is functionality stuff, so we're not going to do anything with that. Rods we already mentioned, and cones. I think that's pretty much it, guys. I don't have anything else regarding new stuff. So let me pause or stop the recording.